Does it feel like medicine has failed you? It's all pills and procedures? Have you seen the overreach in healthcare policy and politics? I want to empower you with the knowledge that you need to make your own best decisions. Welcome to the Underdog RN podcast. Knowledge is power, so empower yourself.
So over the last couple of weeks, I've really dived into burnout. I think this is an important topic for a lot of healthcare workers now for a multitude of reasons. We all know about short staffing, high acuities, and just a general lack of support, whether that's from our direct leadership or what I like to deem the ivory tower. After COVID, I think that we've all felt this to a whole nother level of magnitude. I just see all kinds of things, day to day, nurses that I've connected with over the last couple of years, especially. And, we get into long conversations about just the culture that has been kind of sparked up in this, burned out, just burned out kind of thought processes and feelings with everything. I just saw a nurse who does TikToks talking about ratios of up to 8 and 9, from like posing as the management. And then she's like countering back with, I can only count to 4. And, it's a whole thing. I mean, this is just a wide topic of, it's like an overarching topic with all these branches, it's like the forest. And then we have all the little trees of different issues that create this kind of an issue. In regards to ratios, personally and professionally, in the settings I've worked in anyway, I can honestly say that a ratio greater than 5 is just too much. And even 5 people is pushing the limit in a lot of settings. This isn't to say that 2 patients can't be too much at a time. You see that a lot in like an ICU setting, an ER setting where you have basically an ICU patient in the ER. Even having 4 patients in certain situations. I mean, it really just depends. And this is why it's so hard to nail down a finite nurse to patient ratio. However, hospitals, magnet hospitals, different places nail this down all the time. That's one of the bragging points for a few places now is mandated ratios. And I'm really kind of curious, like how they do that. I'd really love to hear from somebody that works at a place like that. And okay, well, what happens when somebody calls in or multiple people call in? Like, what do you do then? Does your administration come in and help? Do you pull nurses from other units? Do you how does that work to, plan staffing? Cause you can't plan an influx in the ER or not. Do people just sit in the waiting room for a really long time so that you can control the beds upstairs and the beds in the ER? Like, how does that function? Cause if we have this nailed down somewhere, why is it not like that everywhere? I think that there is a place that we can get to. I just don't think that we're there yet necessarily. So that's something I would definitely like to see as far as approaching burnout goes. I really I love nursing. Obviously, it's kind of my niche. And so I really see that side of things. I can't wait to bring you interviews with other people that work in different specialties so that they can, get down to the skinny of what they really see, like an RT, PT, pharmacist, different things like that. Because seeing one perspective is great, even if there is different experiences in areas, but that's nowhere near anything in consideration to when you look at all of healthcare. So I think it's important that we look at what kind of outcomes happen for patients when you have these burned out nurses, right? I think I've mentioned before, but medical errors are the 3rd leading cause of death behind cancer and heart disease. That's error, not just bad outcomes like people, dying from their
cancer or heart disease. That's medical errors occurring in the system every day. And when you have a large population of burned out nurses, your patient outcomes are going to be affected. I hate to even say outcome because this is a person's life, their livelihood. This impacts everyone from their immediate family to extended family. I mean, you can impact a family for generations to come when you're talking about somebody's quality of life, going into the trash or them having a loss of life. I mean, that carries an impact. Like my husband's grandfather passing away has touched everybody in different ways and still does. Holidays and birthdays and, family get-togethers at church. And he was a leader in the children's church. And so all of those kids and my sons who are little, I mean, it goes on. And so I don't believe that errors are really an acceptable kind of thing. Why this isn't a bigger topic of conversation, I don't understand, because I want to dig deeper into what falls under the definition of an error. But frankly, I feel like it's something preventable a lot of the time. I mean, if it's an error, it was not the intended outcome. It was not intentional. So why in the world are we having this? And I get a lot of the factors that people talk about, more complex patients, just we're staying alive longer, so we're sicker. There's more interaction with the healthcare field. More people are utilizing the system, so that increases error. But to be the third leading cause, really? That's just, it kind of blows my mind. And I think that it really is key to get your practitioners and your nurses and your other support personnel involved and out of this kind of mentality. Like, you can't have people who don't care in healthcare. That's a very dangerous combination. When you see this attitude of apathy, well, yeah, I got this done, here's your report. Yeah, I didn't get those dressings done. I just didn't have time. And they just walk out like, I'm done. Okay. I mean, that's not even like leaving a fryer on, or I don't know, something else that causes a building to burn down. Like, you're leaving this person open for infection and potentially costing someone their life. That we can't have that. We can't have no heart in healthcare. As cheesy as that sounds, it's just true. Like, you can't not care, because when you don't care, things don't get done like they're supposed to. And people feel that, right? Healthcare is personal. It's a huge thing. I have recently done more total patient care than I have ever done before in different settings. And so I've really looked at that and realized, like, it's hard, obviously, but it's also very comprehensive. And it gives you the opportunity to observe a lot more. You notice the smaller details, and you can develop more consistent care and build stronger relationships with your patients, which promotes a certain level of trust. Like, this bond of trust that develops between patients and nurses, patients and doctors, doctors and nurses, RTs, your PTs, OTs, like everybody, like, just there's this underlying basis of trust, but that relationship with the patient and each healthcare practitioner is just so fundamental, right? When somebody respects you or trusts you, those two things kind of go hand in hand. And then when you have something to say, something to teach them, something to talk about, a sensitive subject, just different things, like, it's a lot easier. It's a lot better outcome. It's more influential. And so I think it's really important these relationships that we build, and frankly, like the system we're building is squashing that, which is then turning into burnout. Like when you get into healthcare, it's to help people. I don't know anybody except for maybe 1-2 people that do what they do for money. Okay, that's their primary motivator. Most healthcare workers, the majority, are in it to take care of patients, to help people in a time of need. And so when you squash the ability to have any kind of follow-up, right? You have no clue. You put in all this work, all this effort, and then you have no idea how it turned out. You have no clue. When you are just checking boxes and completing tasks, like there's something to be said for standardization, right? Like an intake process, okay? That is most likely going to be standard. Now you're going to delve into some additional details depending on this patient's history or needs or what they're looking for, goals, whatever it is. But generally, that's something that you can standardize. Like, what's your medical history? What's your social history? What's your surgical history? Your genetics, like family history, all this stuff, right? Like that kind of thing. The information gathering, I feel like, can be mostly standardized, right? You're going to, if you have somebody with diabetes, you're going to ask them, the next thing is like, okay, well, do you check your blood sugars? How's your A1C been trending? How do you understand your diet recommendations with that? Like all of those kinds of things, like you can branch off from there. But this standardization of the day-to-day care, that's a problem. People are burning out because we didn't get in this to check boxes. We got in this for the people. I focus big time on building rapport with my patients. I try to figure out what kind of relationship or what kind of support is going to be best for this patient, and then taper my approach to kind of the overall idea. It's so hard to explain. And I think that's why it's so hard to like quantify, why it's so hard to kind of understand or teach it. It's very difficult. Like I have nurses ask me how I talk to, well, how did you handle that? Or how did you talk to this person? Well, what did you say to them? And I don't know. It's so hard to verbalize, because some people just need like a soft touch and some sympathy for a minute because they've been dealing with really stressed out people that are, doing what they're supposed to be doing, but not really taking the time to hear them and talk to them. And that's what they need to kind of get on track. Some people need like a firm hand, like a frank conversation about, hey, like this is what you have going on. Here are the realities of your situation. If you continue on this road, this is what is going to happen. Either way, no matter what direction it is that patient needs, you have to be able to look at that and you have to be able to have those conversations. Building a relationship with people, that's what I love. Like when I can spend 20, 30, or 45 minutes talking to a patient's wife and trying to help her decide, like, do you want to pursue hospice or send your husband to a facility? That's what matters to me. And that's because it's what matters to the people I'm caring for, right? I mean, sure, getting his medications is important and, changing his dressings is important. But when you have somebody who is like, I have no idea what to do. Should I give it more time? Should I do this? Should I do that? What about this? What about that? And they have nobody to talk to because the people that are supposed to be talking to them, the nurses, bridging that gap, aren't. They just can't. They don't have time. They don't have the energy. They don't have the emotional capability. They don't have the mental capability. Like, it's so hard. It's so hard to just want to do that with all of your patients. Like, I was talking to an RT the other day, and there was this patient exceptionally anxious about wearing a BiPAP. And, the RT's like talking to me and they're like, well, I can't be in there for, 30 minutes or an hour, like talking down their anxiety. And and trying to help them understand this and be there so they're not scared or whatever. Like, they're all worked up. I can't constantly be in there. And I just looked at her and I said, what if you could? Like, what if you could? Like, say in a, crazy world, whatever, perfect ratios, perfect world, like you have time. What if you could, like, actually be there for even 15, 20, 30 minutes to just give them some peace of mind, talk them down, stand there with them, have a conversation, and just, hey, I'm just going to sit here with you for the next 15 minutes and let's see how you're feeling, but I'm going to be here so you're okay. And she just looked at me for a minute and she's like, well, yeah, of course I would love to do that. I would love to be able to do that. But I can't. I don't have the time. I have to do this, and just, went on, like, had this list of things she had to get to. And I'm like, this is sad. This is really sad. Like, I do that with patients. My last shift I worked, I did that. I pulled a chair right up to the patient's bedside and just sat there and talked to them. And it puts me behind on documenting it. It makes it where, I'm risking like getting out on time, but it's what they needed. It is what they needed. Like, I will post outside of a confused patient's room. Like, anybody that's ever worked in healthcare, you have yellers, you have people that have this super short-term memory, are very confused, and they just yell, they just scream all day, different things. They forget where they are. They need something. They need to go to the bathroom, they have pain, everything is just yelled because they forget they're in a hospital with a call light and this and that and the other. And so I will post up outside of their room and I will chart there, or, if they have the ability to understand me, I'll tell them, I'll be like, hey, I'm going to go do this or that. And then I'm going to come back, and it works a lot. I do that a lot with like very emotional people that are so anxious or depressed that they, can't focus on their care. Like, I'm just like, hey, how are you doing? How's things going? And they're just very withdrawn or very upset or whatever. Like, really, when you do that and you like look at the time, it really only takes you 10 minutes, 15 minutes. And when you consider that in, the span of the day, that 15 minutes that you gave them, it just changed their whole outlook and perspective. Now, I'm not saying this doesn't work with everybody. We're all individuals, but a lot of people, when they're not engaging, like if you just pull a chair up and sit down and talk to them, it's huge. And then it builds this amazing like relationship between the two of you. You get to know them better and understand them, and can tell when they have things like pain or are distraught or whatever. You learn to read them better and understand them and their feelings and what they're saying, but it's so hard to even tell nurses that they can do that. Right? Like, just take the 15 minutes. I don't have 15 minutes. And it's because the pressure, like, you have to get these boxes checked. You have to get these things done. You have to get, and you're overwhelmed. And like, this is good nurses and bad nurses. Like, so what I'm kind of talking about here, like what burns nurses that really care about patients, that are good at what they do, is when they come into a shift and hear, hey, let me know if you need a hand. You're a strong nurse, so I know you can handle it. What this is really saying, hey, I gave you a heavy team. I'm willing to help you. You got this. So what that meant to me whenever I was a newer nurse, or what I used to hear, hey, I gave you some challenging patients, but I know you are competent and can handle it. I'm here if you need me, but I know you got this. What I hear now, hey, you're going to be strapped today. I need you to carry the load because I don't think this other nurse can, or, you're just down this hallway and I worry about this patient. So I went ahead and threw them on your team, even though I know that kind of pushes you over, and, thanks for being a team player. Let me know if you need any help. maybe that's just the burnout talking. However, I will say I'm not the only one. Like, I had someone look at me the last time that this happened to me and said, "What did you do to get crapped on?" So this isn't something where I'm just overwhelmed or can't handle it. Like, when I talk to other nurses or healthcare professionals, it's the same mentality. Like, you put the load on nurses who won't push back, who can carry their fair share or even more, and then you overload them, and then before you know it, it burns them out. Like, it really makes me dread these shifts. It's not a point of pride or a point of bragging or anything. Like, when I was a new nurse, oh yeah, I can handle it. Yes, sure, please. And you just want to be taken seriously, right? You want to show that you are competent, that you know what you're doing, you know what you're talking about. And now, as a little more seasoned nurse, I'm like, really? Seriously? Like, what? Why do you have to pick anybody like that? Why can't you just spread it out like we're supposed to? I just feel like, so even on these shifts, like, I typically get out on time, right? So I'll get my meds passed, I'll get my dressings changed, get all my tasks completed, all my documentation done. But did my patients really get all that they needed from me that day? Like, I lose that personal connection. Like, I've gotten really good at trying to fit it in. Like, while I'm getting meds ready, I'll have a conversation like, "Hey, are you married? Do you have any kids?" Da, da, da. Like, but even then I'm distracted and they know it. They see me doing a task while asking a question and then waiting for their response. And that's such a superficial way to get to know somebody anyway. I do make a point of, like, sacrificing, staying a little bit late or reorganizing other tasks so that I can give this person the time they need when it's especially pertinent situations like hospice or discharges, future care, like they're a patient who is unstable. Like, I don't shy away from challenging patients or even complex, like, situations. I thrive in those, especially critical patients. I enjoy the organizing, the attention to detail, and the complexity that comes with critically ill people. If people are going to be that sick, I want to be the nurse that takes care of them. I don't wish people to get that sick, but if it's going to happen, it's the same thing I used to say about, like, ER. Like, I don't want people to get into traumas. I just want to be the nurse for someone if that is happening. I would never wish that on anybody. I have been in definitely worse, like the worst situations that I've been in are considerably, and that's the thing, right? Like, we're going to sit here and compare, like, the absolute worst situation I've ever been in and be like, oh, well, where I'm at now is not so bad. It's not that bad. Still not good, but it's not that bad. Or, oh, well, I worked here before, and so and this place is better. Why is that the mentality? Does it have to be this way? Why does it have to be this way? When I was traveling, so I would be the charge nurse in this ER and the flow nurse. So, the charge nurse is, well, in charge. And then the flow nurse puts rooms, like, plays, chess with the rooms, basically. And you have a patient go upstairs, the room gets cleaned, and then you got to decide, like, do you have an ambulance coming in, patients in the waiting room, like, a good time to post that room is available, basically, for, the triage nurse out in the waiting room, or give it to an ambulance. Is that the nurse that's responsible or covering that room, is she in a code right now? Or does she have a patient that's critical and she's having to stay with them? So if you put someone in that room, she's probably not going to be able to make it by anytime soon. Like, so that's the flow nurse. They are essential to an ER, essential. And so I'm the charge nurse. I have a critical patient on a critical IV medication that has to be monitored, like watch their vitals, check, assess them. I've got multiple psych patients with only one psychiatric safe room, so the other patients are out in the hallway. I've got nurses coming at me with their issues or concerns or complaints. I've got one nurse out in triage managing every patient that walks through the waiting room, generally like 20 to 40, 50 patients.
on any given night, and she's calling me like, has this issue or that issue. I've got physicians or practitioners that have needs or questions or about things. I've got ambulances standing in the hallway right here in front of me where they need me to triage the patient and then decide, are they going to a room or are they going out to the waiting room so that the ambulances can get back out into the city to answer more calls. Like, it's just, and then that doesn't include, like, I have medications to give. I have charting I have to do. I mean, it was just ridiculous. It was ridiculous. And this is night shift that I was doing. So there is no administration. There is no, ivory tower. There's nothing. You have your house supervisor. And it was really interesting to me one night. I think it was the CFO. It's like this guy in a, button down tie, slacks, the whole bit. Like, he looks official, and he's walking through the ER, and I'm like, turn around. I was like, can I help you? Do you need something? And I noticed his badge, like CFO, and I'm like, oh, that's interesting. And so, he's like, how's your night going? And I said, well, it'd be better if I had some help. Well, what about your house supervisor? Are you guys doing okay? And I'm like, oh, she doesn't come down until she drops off staffing first thing in the morning. Because there was two house supervisors. One was fantastic. She would come down, she would go to the floor, she would, come run patients up. Like, she was super supportive, and she'd help, with bed placement. I mean, everything. She just managed everything so well. And then the other one, like I said, she would walk down one time, drop off staffing for that day, and oh, I've got this and this going on. And I'm like, well, the other one, she makes it down here to help out some, because we have no staff. Like, there's nobody. And so, I just happened to mention that to him, and the look on his face, I'm like, this is why right here. Again, I've sat across from, a member of the ivory tower and talked about, like, what is going on in the hospital, and when they looked at me and was just like, why is turnover so bad? Why is everybody so unhappy? What is going on? What's the big deal? And I'm like, the fact that you don't know, the fact that you have to ask me why all your nurses are leaving, why the turnover is so bad, where's your middle management? I didn't say this to them, of course, but where are they? Like, if there's this huge disconnect, I'm just going to tell you right, here's a hint. If you're a CEO, CFO, COO, CNO, whatever role, if you're in that role and you don't know why people are leaving, there's a problem. Either you're not approachable for some reason, people don't have access to you once you get so big in these administrations, or your middle management between your frontline workers that are leaving and you is failing you. And it's not to say that there are great managers, there are great supervisors, directors, everybody. It's the system there's two main reasons for this that I've seen so far. It's incentivized not to have problems. Bonus checks, promotions, all these perks, not to have problems. Meet this standard, don't have problems. Here you go. We're going to pay you this ridiculous amount of money. Okay. If you have a business, you are going to have problems. It needs to be about how you manage those problems. What are the problems? What are the solutions? What is this manager, director, whoever bringing to you? Like, hey, we have this problem. This is why, like, we have the staff are coming forward mentioning this. So here are some solutions that we've come up with. This is what we need from the company. This is what, implementing that looks like, and here's the expected, like, outcomes. I mean, what? If you don't know what's wrong in your company, there's something going on. If you're not approachable, if people want to send other people to talk to you, there's a reason for that. Is there no chain of command because they don't have anybody to go to because they know that you all know each other?
Is there a concern for retaliation? Like, are they worried they're going to lose their job or get written up or not get vacation approved? I mean, what's going on here? I mean, and these are just the things like I've seen. You know, I think I've mentioned before, like it's all the who you know kind of system. And rather than taking out these factors with the, you know, nudge, nudge, wink, wink, like here's this, we'll put you here and blah, 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 kind of referral, whatever, you know, and then the employees see that. Like the employees see like that somebody gets denied for a position because they don't have a degree while somebody else gets given an even higher position and have no degree even in that area of expertise, period. And that just doesn't make sense. And in this podcast, we are in it to make it make sense. So what do we do? What do we do about all of this? Right? Like, frankly, I'm at a point, and air quotations here, I don't want to be a strong nurse anymore. You know, what does that offer me other than a really hard day where I don't feel like I met all the needs of my patients like I needed to. And, you know, I don't know. Maybe there's hope. I doubt it. I'm not sure I'm interested. But administration was my last goal in the mainstream system before, you know, COVID wrecked everybody's lives. And I'm not a yes man. Like, I am not afraid to ask the hard questions, point out the elephant in the room, you know, do what's best for the patient rather than just whatever is the standard. You know, like, so where does that leave me? I have a huge passion for this. I love nursing. I love taking care of people. Like, the kind of busy I'm talking about is not, oh my gosh, I actually had to work for 12 hours. This is, I have to be in 3 places at once. You know, I go for half of that shift, 6 hours straight, and have not stopped moving. Like one room to the next room, to the next room, to the next room, to the next room, like down to the bedroom, down to get drink, down to get this, down to get that, like run here, run there, all of it. Like you do not stop. And you need to be in multiple places at once. Like you have a patient crying in pain, and then you have another patient that needs their dressing taken off and changed because they are all wet or it's saturated through or whatever's going on. And then you need to go talk to the doctor about medication for this other patient whose blood pressure is high or low or whatever. Or, I mean, you can't possibly be in all of those places at once. And that's where prioritization comes in hand. That's what your nursing instructors will tell you. But how do you prioritize somebody bawling and crying, doubled over in pain, a dressing that needs to be done? That sounds like, I mean, what I'm setting up here is a terrible nursing question. This is the nursing question that you're like, oh my gosh, they're, you know, all right, but all wrong. What do you do first? You know, and you can only be in one place at a time. And when I say not stop, I mean, you're going and you're giving meds, you're turning around, you're leaving. Not much conversation in between. You know, I just think about like the joy, satisfaction, pride, like real pride in what I'm doing, real connection with what I'm doing when I see a patient discharge or have a good outcome. When I get to see someone feel better, or just even when they take, like, there's this deep breath, right? Like you walk in and you have a very worked up person. They're angry, they're sad, they're anxious, whatever it is. And you're like, hey, what's going on? And they're like, I don't know. I have this, that, or the other. And they're just really stressed out. And they don't understand anything. They have all these questions. Nobody's giving them answers. They've been asking for answers. They're overwhelmed. They're worried. And then you just take the time to like really answer all their questions, explain everything calmly. Say, okay, hey, well, let's look at this. Let's look at that. This is what you need to know about this. Like, people take this like,
They take this deep breath. And so look like how that makes me feel, bringing someone else that kind of comfort, knowing that I had an impact. That's why I do nursing. That's what matters to me. I just struggle with how we are trying to systematize all of it. Like there's like what if you're a nurse or any kind of specialty, really, you can apply this, to whatever you're doing. If you were able to actually like work off of a care plan, like an old school care plan that they talk about. And I don't mean like the crazy ones that you had to do in nursing school. I'm saying like a legit care plan. Like this patient comes in with, I don't know, heart failure. Okay. And they are going to like goals, right? They're going to know that they should check their weight daily. They're going to be able to make low sodium choices in their diet. They're going to be able to, they were able to ambulate, 150 feet without problem, at admission and, or prior to illness. So we're going to get them back to that, or at least back to 100 feet, 75 feet, whatever. Like you had these things, right? And then when you take over care of that patient and they're like 3 days into their admission and you look and you're like, okay, well, they stayed on room air all day yesterday, or they went from 5 liters to 3 liters. Okay, great. All right, we're making progress there. Let's see where we can get today on that. They walked 25 feet and got very short of breath. Oh, okay, good to know. Like we need to look at that. Do they maybe have some more fluid on board that we need to diurese off? I mean, really thinking through patient's care, not looking at the computer and being like, okay, it's telling me to give this medication now, so I'm going to go give this medication. It's telling me to assess this now, so I'm going to go assess that. Like, where is the critical thought in that? There isn't any. It's literally the system trying to tell you exactly what to do, and this is why medical errors are the 3rd leading cause of death. I mean, how many of you, if you're in healthcare, how many of you would feel completely confident, right? If you're in a car crash right now, you're like, oh yeah, if I was in a car crash right now, that's okay, because I know that from the time I get to the ER till the time I get discharged, like I'm gonna be well taken care of. Everything is it's gonna be taken care of. I don't have anything to worry about. And I'm not saying that like you shouldn't have, some kind of obligation in your own care, but like really, I would be concerned. I get concerned all the time. I'm like, if my husband was ever admitted to the hospital, I'm gonna have to take FMLA or something, because there's no way I'm not leaving his bedside, but we also have 3 kids. Like, what am I going to do? I'm going to have to leave, I can't just leave my 3 kids at home alone, or with family 24/7, but what's going to happen in the time that I'm not there? Like, I have seen it. I have seen, mistakes. I have seen, and we are human, right? Error happens. It's just to such a degree that it's very concerning to me, and I don't understand why this isn't, the focus of JCO and CMS and everybody else. Like, errors, not, infections are important. They absolutely are. Readmissions, like all this stuff, the overall idea of a lot of these things, it makes sense. Okay, it does. It makes sense. But it's not doing anything to improve the system. Like, frankly, it's like a bunch of regulatory stuff that just comes down, rolls downhill, and stops at the frontline person. And they're like, well, I need to do these things. Like, this is what this person needs from me. Do they need an infection? Absolutely not. But do they also need somebody to
Like, help them figure out their housing? Like, do I need to get them a caseworker? Do I need to get them, these resources, those resources? Or maybe they're just depressed and had something terribly traumatic happen to them, but nobody has the time to stop and talk to them. Like, I don't know how many times that happens. Like, somebody has a patient with a terrible history, comes in, and then you get this story from the nurse, then you get this story from somebody else, and you get, and nobody, I'm like, have any of you actually just like sat down and had a conversation with them about it? And it's just, and this is what makes me tired. It makes me, I don't want to be the strong nurse anymore. Like, it's exhausting. And it's, frankly, it impacts my patient's care. And that's not fair to the people I'm caring for. And I think, like, this is why, like, health advocacy is so important, But when you don't want to be the strong nurse anymore, like, who's advocating for you? Right? That's why this is important. That's why building relationships is important. That's why fostering relationships, with the people that you're around and supporting each other, and I don't know what the future brings, but I'm hopeful that it will be good things. I really do believe that we can create a system that really is centered on the patient, but healthcare is a business, but it's not just a business. And I think that we need to figure out how we juggle what should be standard and what should actually be responsible, critical thinking on behalf of healthcare workers and professionals. I appreciate you listening. I hope you have a great day. Thank you for tuning in today. I hope that you found some of the information insightful and helps you advocate for your own care or someone else's. I want to encourage you to follow me on Twitter, Rumble, YouTube, Telegram. You can also find me at my website, underdogrn.com. Knowledge is power, so empower yourself, and let's make it make sense.